Good evening, everybody. I think most of you probably know me. I am Allison Foss. I'm the Executive Director of the Myasthenia Gravis Association. Tonight we have McKenna Fulton, our Community Program Coordinator in Kansas City, also on. We are so glad that you're here. If this is your first time joining us for our virtual monthly meetup, we meet the fourth Monday of every month from 6:30 to 7:30 Central Standard Time. We'll send out a survey following today's programming, and in that survey, we'll list out the upcoming webinars for July. We have a couple of them. One on July 18th about the ADAPT Seron study that argenx is putting on, and that is at 5 p.m. Central Standard Time. And then our July virtual monthly meetup on July 22nd will be UCB joining us to talk about generalized myasthenia gravis. So we hope that you'll join us for those upcoming webinars as well. Tonight, we're thrilled to have Dr. Tina Ipe here with us. Dr. Ipe is based out of Little Rock, Arkansas, and she is the owner of Regen Medicine. And she's going to talk tonight a little bit about plasmapheresis or plasma exchange and how it benefits myasthenia gravis. She would like this to be interactive, so if you have questions as we go through, please put them in the chat. It should be enabled, and we will watch for them. Dr. Ipe, I'll let you take it over.
Perfect. Thank you so much, Allison, and the Myasthenia Gravis Association for allowing me to. I know that, I met a few of you at a patient advocacy meeting. So since I can't see your faces, who is on, but I look forward to getting to know more individuals that attend this meeting. A little bit about what therapeutic exchange does, especially for neurological disorders. And in particular, because I'm speaking to you all, we're going to really focus on myasthenia gravis. Now, I do, my training was in at the University of Pennsylvania, and we really spent a lot of time trying to understand and try to utilize evidence-based guidelines when it actually came to treating patients with therapeutic apheresis. And, in this case, when we are treating patients that have myasthenia gravis. Neurological disorders are a huge passion of mine, and I participate in a lot of advocacy groups, including the American Society for the American Society for Apheresis, as the chair for the neurological diseases subcommittee, but also for patient advocacy at ASCP. So a little bit about Regen Med. Regen Med is a clinic that is actually based in Little Rock, Arkansas. And as Ms. Boss mentioned, I opened this partly because I saw a huge dearth for patients to receive therapeutic apheresis outside the hospital setting. Many of you know or have experienced, being hospitalized or receiving your chronic treatment as a patient in hospital settings. And those of you who have been treated with therapeutic apheresis, predominantly you have received it even in the hospital setting or in an outpatient setting that is associated with the hospital, and not truly a true outpatient setting, that is one that is not associated with any hospital. So I just want to go back to a couple of slides earlier. So I, am the medical physician and the person who leads Regen Medicine, but I'm also an associate faculty member at the University of Arkansas because I am very passionate about education, especially as it relates to patient education to our residents and fellows. So what does Regen Med do? We really aspire to become a holistic medical home for individuals that have autoimmune disorders. And in particular, because my passion is neurological disorders, we really focus on patients with neurological diseases. We are able to actually provide multi-specialty infusions as well as therapeutic apheresis in our settings. So, we can actually provide infusions such as eculizumab and things like that at our multi-specialty infusions. And the way we decided to do it was actually to try to provide patient access to these treatment modalities, even though they're not actually adequately reimbursed, especially for therapeutic apheresis. And so with that, while we are fully supportive of patient advocacy and education, one of the advocacy that we're trying to do as Regen Med is actually help CMS understand better how to reimburse patients that are receiving therapeutic apheresis in a true outpatient setting. And so we will actually be one of the first non-hospital-based therapeutic apheresis centers in the United States. And everywhere else, it is actually a direct bill to patient, and they don't work with insurance to try to provide this care. So we're trying to change that. So hopefully we will be successful. So, I'm not really going to talk about myasthenia gravis because a lot of you, you all deal with myasthenia gravis and you have your patient-specific symptoms that is associated with it. Now, I mentioned that we wanted to serve as a holistic medical home for patients that have autoimmune disorders. And so because of the holistic perspective, we do take into effect that neuroinflammation, in this case for myasthenia gravis, which is an autoimmune disorder, really functions to cause a lot of the cell damage and create symptoms not only about respiratory fatigue, but it also, creates a lot of other issues that you're well aware of, including cognitive impairment. So the effects are varied, and it really does affect the whole person as a whole. And so while we do provide therapeutic apheresis as well as multi-specialty infusions, we also look for holistic mechanisms to try to decrease this neuroinflammation. So we do take it from more of an integrative functional medicine perspective as well. And for those patients that are capable of doing all of the different things, we try to encourage things like meditation, deep breathing exercises for them to receive their therapeutic massages, change their diet, so that any allergens really don't increase that neuroinflammation that already exists, or this autoinflammation that already exists in myasthenia gravis patients, but also focus on some vitamins and herbal therapies, as well as focusing on this anti-inflammatory diet. Again, our perspective is really to encompass the whole patient and not just treat one symptom as it relates to neurological disorders. Now, I'm going to, before I jump into therapeutic plasma exchange, I wanted to know if there were any questions regarding anything that we've spoken about. And I'm sorry, I can't see your faces, so I guess not. So, can you all hear me? Hello?
Yeah, we can hear.
Yeah.
Well, the participants won't be able to, but they will type the questions in the chat if they have any.
Okay, perfect. So far, no questions, right? Now, I do encourage all of you to really speak up. I love, having an interact session, and I think that's a hard part about virtual presentations, is that while it really gathers us all in one place, we're really not able to form that community, or I can't actually see your expression and understand your question. But anyways, we talked about the holistic part of taking care of individuals that have neurological disorders, but let's talk about what therapeutic plasma exchange is. So as you can see in this schematic, the whole aspect of therapeutic plasma exchange, otherwise known as plasmapheresis, is that plasma exchange replaces a portion of the patient's plasma with a replacement fluid. And depending on how the patient is doing in terms of their coagulation, which means their bleeding risk, we are able to replace the whole blood that we have taken from the patient with either albumin, 5% albumin, or FFP, otherwise known as fresh frozen plasma. So if we go from left to right, from step 1 to step 5, what occurs is that there is a machine, and most machines in the US is based on the centrifugation principle. And what it does is that the patient's blood enters this machine. There's a centrifuge that you can't see, but the individuals that perform apheresis are able to see this little port. And in this port, we actually see that the centrifuge whole blood divides itself into different layers. And it layers itself from the thinnest or the less viscous, being plasma, from the axis of centrifugation out to the most densest, which is red cells. So you can see plasma, then what we call the buffy coat that also has white cells and platelets, and then you have the red cells. And what you see is that step 3, it's really considered waste, but it's plasma that we're actually removing. Now, we don't remove all of the plasma, but we remove a significant portion of, the plasma. And what occurs is that the reason we remove plasma is because it has these autoantibodies that are mediating the symptoms of myasthenia gravis. And once we remove plasma as a waste, what we do is to ensure that there is the blood still remains viscous and not thick, without that plasma component. We actually replace it with either 5% albumin, as I mentioned, or fresh frozen plasma if the patient is at risk for bleeding or is going to a procedure either that same day or the very next day. Because one thing we don't want our patients to do is to be at a higher bleeding risk once they're finished with the procedure. Now you can see that what happens between step 1 and step 5 is that, again, in the centrifuge, the blood kind of gets mixed together, it combines, and then returns to the patient. So that is what therapeutic plasma exchange or plasmapheresis does. It's a removal of autoantibodies that is present within the plasma that mediates illness in patients. So I talked a lot about this, right? I talked about the fact that there is a centrifuge that you all cannot see, and the blood components are really separated according to the specific gravity or the density of the blood component. And what happens is that if you go from the center of axis of rotation, what you see is that the least dense, which is plasma, is closest to the axis of rotation, and then you have what we call the buffy coat, which includes the platelet, the lymphocytes, and the granulocytes, and then you have the red cells, and these are the various components of our blood. So I briefly talked about, in the case of myasthenia gravis, what we're trying to extract out most is immunoglobulins, but anything greater than 5,000 kilodalton is actually removed in this non-selective process of removing autoantibodies or alloantibodies. So immunoglobulins like IgG, IgM, IgA, they do get removed in different fashion. So what I mean by that is that IgM, which tends to be predominantly found in blood because it is a pentamer, gets removed more efficiently than IgG or IgA. IgG, which tends to actually be found on the on the cells, what happens is that when IgM and a certain proportion of the IgG or immunoglobulins are removed, it creates this concentration gradient. And all of you, if you go back to your biology and the principles of biology, you remove that when there's a concentration gradient that is created, things go from a higher concentration to a lower concentration. And that is what occurs, is that IgG kind of lets go from the cells and diffuses down its concentration gradient into the blood vessels. And then again, the reason for why we actually do therapeutic plasma exchange for multiple days is because once this concentration gradient is created, we actually continuously remove IgG in addition to the other immunoglobulin. Our true focus is really the removal of antibodies that are mediating myasthenia gravis. But as I mentioned, therapeutic plasma exchange is a non-selective process. So anything greater than 5,000 kilodaltons actually get removed. So there are certain things like immune complexes, paraproteins, as well as coagulation factors that do get removed. And that's why we tend to focus very heavily on what the clotting risk of the patients are, or the bleeding risk of the patients are, and monitor that very closely of the patient. There are also things that we also monitor, such as electrolytes. Electrolytes also do get removed, like calcium, ionized calcium in particular, and partly because we want to make sure that the patients don't have symptoms such as tingling and develop any mild but adverse events during the procedure. Now, when we actually remove these immunoglobulins and cytokines, for example, what you actually see is that therapeutic plasma exchange is believed to actually mediate immune changes. And the immune changes are truly beneficial for individuals with neurological diseases as well as other autoimmune disorders. Now, the thing about autoimmune disorders is that there's this immune reaction that is created, in that there's an increase of the B cell. And this increase of the B cells basically causes autoantibodies to be pumped out into the blood. And when you have that, guess what? Your T cells are suppressed a little bit. And so what therapeutic plasma exchange does is that it rebalances the immune system. So it causes a decrease in the B cells. And when you decrease the B cells, you're actually going to decrease the autoantibodies that are produced. You're going to increase the regulatory T cells. And what these regulatory T cells do is that it actually mediates or decreases autoimmunity. Again, very positive benefit of therapeutic plasma exchange. It also promotes suppressor T cell function, which is also important to suppress autoimmunity. And it causes this alteration in the T helper ratios. So the T helper ratios in autoimmune disorders tend to be T helper 2 greater than T helper 1, and this rebalances out a little bit more towards the T helper 1 rather than T helper 2. So it's a lot of immunology. So we as blood bankers are really, we have to fully understand a lot of diseases, but we also understand testing of blood, and we also closely monitor how things are being shifted. And we have seen through a lot of studies is that there is this immune change that is truly beneficial for patients that are receiving therapeutic plasma exchange. Now, as we talk more, we will, I will highlight some other things that are functionally very important about therapeutic plasma exchange. Okay, so now you must all be wondering, how is it that, how long has therapeutic apheresis been used? And do we really know whether this works or not? And so I just want to reassure you that therapeutic plasma exchange has been performed for a long time. And, right now, in 2023, the 9th special issue edition of the guidelines for the use of therapeutic apheresis in clinical practice has been published. So it has been, all of this is really evidence-based guidelines, that has individuals. These are all physicians as well as researchers from different specialties that get chosen to review the literature for the past several years, usually about 2 to 3 years, and they review the literature to see what are the most recent studies that either are stating that therapeutic apheresis is either beneficial or is not beneficial. So through the evolution of this whole guideline, we at one point in time, there was a push to do therapeutic plasma exchange for schizophrenia. But, a lot of clinical data and clinical research has shown that there is no benefit of therapeutic plasma exchange in schizophrenia. So we don't do it anymore. And I will walk you through exactly how we evaluate therapeutic apheresis efficacy. So the evaluation of therapeutic apheresis is really determined by 3 different things, and I have listed them for you. Basically, we need to know if there is a clear mechanism or a clear rationale for the use of therapeutic apheresis. For those of you who may or may not know, therapeutic plasma exchange is just one of the many therapeutic apheresis modalities that are used. If any of you also suffer from having sickle cell disease, you know that we can actually do a red cell exchange where we remove the sickle cell and replace it with donor red cells that, have a longer, that don't have that sickling pattern and, are not prone to low oxygen conditions and things like that and don't become sickled. So those are so that's red cell exchange is another one. So there are many other therapeutic apheresis modalities that we use. If anyone has had a really high white cell count, you know that we can actually do this process called leukapheresis, or a collection of white cells, so that we can actually decrease the disease burden in individuals that have a high white cell count, and the high white cell count can cause sludging. So each of the therapeutic apheresis modality, we have to have a full understanding that there is a clear rationale for why we're doing what we're doing. Now, once we actually do perform the apheresis procedure, we want to make sure that whatever abnormality objective abnormality it is that we have stated is going to occur, we want to make sure that it occurs. So for example, in this case of myasthenia gravis, I mentioned that the autoantibodies are present in the plasma, and we have removed the plasma that has these autoantibodies. The plasma then gets tested to see if the autoantibodies are present, and we actually take a look as to whether we have actually decreased the amount of autoantibodies that are present in the patient. So is there a corrective evidence that the apheresis actually did what we said it does? And then, of course, not neurological disorders, as are, there are many of the neurological disorders, the titers don't correlate with the symptoms. So another thing that we have always tried to do is that, does the patient have a clinical benefit? Are it's a patient's symptoms decrease? All of these things are fundamentally important for us to understand. Okay, so now that I've mentioned, we actually evaluate therapeutic apheresis using those 3 core tenets. There are, based on the ASPH guidelines, every study that is conducted in the past 3 years since the previous guidelines was published undergoes a process where we try to determine whether, the disease or what kind of evidence or what kind of study gave us the evidence that it works. So for example, it ranges from a category 1 to a category 4. And a category 1 is any disorder where apheresis is accepted as a first-line treatment. And that doesn't mean that, apheresis is only used, but it can be used in conjunction with other medications or other things, but it renders benefit to the patient. So for diseases or for a category 1 indication for a disease, what it has to be really based on is usually randomized control trials. So if there are significant amount of randomized control trials, it actually lends itself to that disease and its indication receiving a category 1 indication for therapeutic apheresis. And as you can see, as we go further down, a category 2 is accepted as a second-line treatment. Category 3, it's really dependent on the patient. Most neurological disorders especially the ones that don't have randomized control trials, fall under the category 3. And then a category 4 is one where the American Society for Apheresis requests that an IRB approval is required or desirable before therapeutic plasma exchange is done. Again, we do all of this such that the benefit to the patient outweighs the risk. And if you take a look, any medication, any treatment that a patient receives is always associated with risk. And we just want to make sure that the benefits actually outweighs the risk to the patients. So I had talked a lot about, apheresis, and you can see that there are a lot of neurological disorders or diseases that are treated with therapeutic plasma exchange. I'm not going to read it all to you, but you can read it or, review this presentation at a later time. But one I do want to note, kind of highlight, is myasthenia gravis, which is in the center circle for y'all. And you can see that myasthenia gravis has been given the number 1, and the number 1 actually indicates that it is a category 1 indication. So what do I mean by that? There's a lot of clinical studies, including randomized clinical studies, that is showing that for myasthenia gravis, in the acute situation, that it is a category 1. So if you are rapidly decompensating, have entered into the hospital, it is a category 1 indication for as a treatment. Now, often, steroids as well as therapeutic plasma exchange is done at facilities that have this service available. One caveat to all of this is that not all hospitals actually have individuals that are transfusion medicine trained, such as myself, and who fully understand the indications for which therapeutic apheresis can be used, and which patients would actually benefit from receiving therapeutic plasma exchange versus not. So most often, most hospitals actually have IVIG rather than therapeutic plasma exchange. So we will talk about the difference between TPE versus IVIG in the next few slides. Okay. So let's briefly talk about the ASPA guidelines for neurological disorders as it was mentioned in 2023. And you can see that as I mentioned, for myasthenia gravis, there are two indications. And the two indications is the acute short term, which is the situation where a patient is either, is rapidly decompensating and has entered into the hospital and needs an exchange quickly so that they don't go into respiratory failure or any of those issues, or it is a patient that has actually been diagnosed with myasthenia gravis for a while, but has not received the treatment, had not received the appropriate treatment and is now decompensating. So those are the usual indications that a patient enters in. And so for the acute short term, it has a category 1, meaning like there's a lot of studies that have been done. Now, if you take a look at the second indication, which is the long-term or the chronic use of therapeutic plasma exchange for myasthenia gravis, you can see that it's a second-line treatment. And I will postulate, and I will let you know that, at least the patients that come to Regen Med, we would like the long-term individuals that are stable, but, need a treatment every so often to basically not put them at an acute risk or acute decompensation where they have to enter the hospital. So long-term really means patients that have chronic myasthenia gravis who receives therapeutic plasma exchange at timed intervals to prevent them from actually having to go to the hospital with an acute crisis. And you can see that the reason why it's a category 2 is that it has been in the last several years, in the last 15 years or so, where, there have been more and more research that's actually saying that patients would benefit from interval exchange with any therapeutic apheresis rather than, just providing it when they are acutely decompensating and have entered hospital. So when we actually take a look at the world in general, and we look at the different, associations and that work in neurological disorders, you can see that I had mentioned the American Society for Apheresis as being, as having provided the all of the things that I'm talking to you about. And you can see that, for individuals that as we called it, acute, either moderate, severe, or pre-thymectomy, it was a category 1. Now, if you take a look at the European Federation, they also agree that, for acute exacerbation of individuals that have myasthenia gravis, it is, again, a level A, which means the highest grade possible for receiving therapeutic plasma exchange. And it also follows, again, in line with the American Society for Apheresis, where they're just saying, okay, we're not seeing the same level, but you can see that they have downgraded it just a little bit to a level B. But you can see that, when you take a grade 1C, it is a lower, the studies that are supporting, or the evidence that was used to support the grade or the category was not a randomized controlled study, or there weren't enough randomized controlled studies. And so that is why there is a level A versus a level B as it relates to the European Federation. Now, the Myasthenia Gravis Foundation consensus in 2013, did agree that, patients should receive, like, therapeutic plasma exchange is a treatment of choice for those that have short-term, who are in myasthenic crisis, as I mentioned, who have refractory MG. So I would consider that more of a chronic patient. And then prior to corticosteroids, and also those that prior to thymectomy. So, any surgical procedure puts patients at impending risk, and that is why most patients receive therapeutic plasma exchange prior to receiving any having their thymus removed. Now, again, the category seems to be in line again with the German Neurological Society. So there seems to be a lot of evidence supporting the use of therapeutic plasma exchange in myasthenia gravis. I'm going to take a short break here and see if there are any questions before I continue on. Okay, hearing none, I will keep going. Okay, so as I mentioned, a lot of the treatment for myasthenia gravis, we can do therapeutic plasma exchange either as a standalone therapy or along with other treatments. So you can see that pyridostigmine, the clinical effect is very fast. So 10 to 15 minutes. Again, this is for someone who deals with myasthenia gravis, needs to take it on a daily basis. So we do want that medication to act quickly and to provide that clinical benefit to patients. In comparison, therapeutic plasma exchange takes about 1 to 14 days just for the patient to see clinical effect. Again, if you consider the situation that patients are receiving therapeutic plasma exchange, usually in acute crisis or to prevent the crisis, you can see that, the days will be a little bit, it takes about 7 days or so to actually have a patient that has a significant symptom burden to actually see relief from it. And it also does take, depending on the kind of symptom that is present, like for example, patients that have ocular myasthenia gravis, it actually takes a whole lot longer. And you can imagine why. The reason why that is because ocular myasthenia gravis, most of the antibodies is present in the central nervous system, the spinal fluid. And so it takes a longer time for those autoantibodies to be removed from it. So there is ocular myasthenia gravis actually takes a long time, usually takes about months before you actually see this symptomatic relief with plasma exchange. IVIG, you can see in comparison to plasma exchange, takes a whole lot longer. It takes 1 to 4 weeks to actually see benefit. And then, same for the other treatments, depending on if it is an immunomodulator, you can see that it will take 2 to 6 months, 3 to 18 months, all of that for the patient to actually see clinical benefit. So plasma exchange, before any of these treatments are given, actually have a lot of benefit to the patient. And you must ask me why. Why is that? And the reason is that we are actually removing the autoantibodies that have bound to the receptors that is mediating the symptom. So if we actually remove the autoantibodies that's present on the cell, blocking the cell from receiving any other neurotransmitter input, guess what happens? Once we remove it, even medications can actually bind to the receptor, and patients can actually have more clinical benefit from the use of plasma exchange plus a treatment, when both are given. So plasma exchange, certainly has a place in actually removing the autoantibodies such that the patient can actually get the benefit of receiving treatments like prednisone, mycophenolate, cyclosporine, and the countless other medications that are present. Okay, so
Right, but it looks like you have a question in the Q&A. Do you want me to read it to you?
please, because I can't, I'm unable to see it.
Yes, it says, how far in advance do you suggest the TPE before surgery?
Okay, so I would suggest, depending on how the patient's coag status is, at least 7 days prior to it. I've had patients that will do it if they have good coagulation or like they're not at bleeding risk. You can do it up to 3 days before the procedure. Because, we're trying to get it where we're removing the autoantibody. So there's clinical benefit, right? To removing the autoantibody. And in addition, we're not putting the patient at bleeding risk.
Thank you.
Absolutely. And like all of the coagulation factors, they depending on which one it is, takes roughly about 3 days for it to go back to the same level that it was. So that's why. So great question, by the way. Okay, so now when we take a look at myasthenia gravis results, when we actually use TPE in addition to the different standards of care, you can see that there's real clinical benefit that patients have. You have a reduction in disease severity by 2 grades, and this is experienced by 89% of patients. Of course, this was a small study, but still, I mean, most of these studies tend to be smaller, again, partly because, you know, myasthenia gravis is a rare disease, right? When you compare it to all of the other diseases in the population, it is a rare disorder. And, not all of the centers in the United States actually have access to therapeutic plasma exchange. There are very few that do. So, for example, in Arkansas, there's really only one hospital, QAMS, that predominantly treats patients with therapeutic plasma exchange for the state of Arkansas. And I'm sure that, all of you, have similar experience. Having worked in Oklahoma, there are only 2 hospitals in Oklahoma that actually do therapeutic plasma exchange. So, the southern states, there are not as many hospitals that actually have therapeutic plasma exchange. And in addition, there aren't that many individuals that are trained in transfusion medicine to be able to perform these procedures effectively. Okay, so now let's go back to the improvements in the myasthenia gravis disease scale. As I mentioned, we always want to have objective parameters that we're following in patients. And in this, when they took a look at the scale, they showed that 78.7% of patients had clinical improvements in their disease scale. There was a functional grading improvement as well. And you can see that 81% of 16 patients actually fully recovered from a myasthenia gravis crisis. So, I know that I might be really biased, towards using of TPE, but I know that, when I have, I will tell you that objectively, I have seen that there are subsets of patients who do really well with IVIG and subsets of patients that actually do well with therapeutic plasma exchange. And I think we're trying to, at this point in time, really try to elucidate which patients are actually improving with IVIG versus TPE. But for the most part, according to clinical studies, you will see that there is a greater benefit to patients with TPE than IVIG. And yeah, okay. So let's talk about MuSK-positive myasthenia gravis. So MuSK-positive myasthenia gravis is actually like when we take a look at therapeutic plasma exchange, MuSK-positive myasthenia gravis patients actually do a whole lot better with therapeutic plasma exchange than those that have the acetylcholine receptor antibody. That we really know of a few subsets of myasthenia gravis patients, and you can see that each subset of patients does differently with the treatments that are provided to them. But MuSK-positive MG patients, you can see that 51% actually improved with plasma exchange when in comparison to IVIG, only 20% improved. And again, 93% actually improved with plasma exchange rather than with IVIG. 2 different cohorts. Now let's look at the reason why patients actually improved with with TPE. So as I had mentioned earlier, when you take a look at therapeutic plasma exchange fundamentally works on the principle of removing antibodies and other proteins in the blood that is greater than 5,000 kilodaltons. And so what you can see is that when you take a look at the immunoglobulins leveled, you can see that when a patient actually comes in, like an individual that has myasthenia gravis, you can see that their levels can vary. But regardless of where they start out with, we haven't actually seen a true correlation with the immunoglobulin and the symptom severity. So please don't let that concern you, because even though this person has a really high immunoglobulin level, their symptom might not be as great as this person right here. So don't let that faze you at all. However, what I am trying to use is that an individual that has a higher level of immunoglobulin, you can see that once you start therapeutic plasma exchange, you can see that sorry, and I want to correct myself. I was actually focusing on a different slide. So what this one actually shows is the different levels of immunoglobulin. So for example, the one that is totally shaded lighter up at the very top is your total IgG level. And then you can see that you have the dotted line, which is your IgA level, and then the least, which is the IgM. So my apologies for misspeaking. So these are the different types of immunoglobulin and their varying levels in a patient. And what you can see is that in a patient, and we'll just focus on the IgG, you can see that when you start instituting therapeutic plasma exchange, their levels do go down. So, but there's a little bit of increase in the immunoglobulin post TPE. So the shaded area that we are looking at right here is the immunoglobulin level pre-TPE. And then once you start it, you actually do end up decreasing your IgG, IgM, and your IgA. But there is a little bit of rebound, as I mentioned, not as high as the first time. The levels have decreased, but depending on, like from their baseline, you can see that their levels did decrease. Now, when we start to focus on, and the different immunoglobulins diffuse differently. IgM, as I mentioned, is a pentamer, so it stays within the bloodstream. And so you can see that that one, doesn't mediate myasthenia gravis as much, but you can see that it tends to remain relatively the same, but just a little bit lower than where the patient started. So you can see that it does increase a little bit, but does not go back to the relative baseline as it did previously. Okay, so now again, when we take a look at, in this case, it was myasthenia gravis related to the acetylcholine receptor. And you can see that this one actually resulted in a decrease of the autoantibody titers. Again, this is pre-TPE, shaded is pre-TPE, but then you can see that there is when in comparison to where the patient started, you are having a decrease in the autoantibody level. But again, there is a slight increase, which happens, right? Because if the patient was not treated with something like rituximab, where you actually remove the B cell population and you remove the body's ability to make immunoglobulin, guess what? Your body is going to readjust itself and you are going to have antibodies reform. And that's a good thing, right? Because antibodies are responsible for providing us immunity. We do want for patients to have the protective antibodies. The problem is that when the body increases its protective antibodies, the autoantibody titers also increase naturally. Okay, now you can see that when you take a look at, I told you that therapeutic plasma exchange removes proteins, and one of the proteins that it also removes are cytokine levels. And cytokines, as you know, are basically are basically proteins that signal to our immune system to actually ramp itself up or ramp itself down. And so you can see that there are various immunoglobulins that are cytokines that are decreased with TPE, including like TNF alpha, IL-6, all of that, which tend to increase that pro-inflammatory response of cells. And then again, we are talking about the fact that we want the T cells to increase, especially the regulatory as well as the suppressor T cell, which dampen the autoimmunity. And we want the B cells to be decreased. And you can see that the T cells are certainly increasing post TPE, and the B cells in white are decreasing post TPE. So that is all, what I'm showing is actually mechanistic evidence that it is, that therapeutic plasma exchange works, in mediating or decreasing autoimmunity. Now, again, I told you that, we do want to shift that ratio from the T helper 2 predominance, which promotes autoimmunity, to the T helper 1 predominant. And you can see that it is happening here. And then, the cytokine levels that are part of that response. Okay, so now I told you that I will come back to this whole thing about, IVIG being really used more than therapeutic plasma exchange because it's more available to patients than therapeutic plasma exchange, which is only available at a few hospitals in the United States. But in the hospitals that have performed it, this is actually a study that I had written or had, it's a meta-analysis that was done in 2021, and I was the lead author on it. And what we actually showed is that when you compare TPE with IVIG in patients that had acute myasthenia gravis, patients that were in crisis had a positive response, at least a positive 19% response to TPE over IVIG. And this was statistically significant. When you take a look at the various studies, including the randomized controlled studies, as well as the retrospective analysis, patients that were treated with TPE consistently had a higher response than those that were treated with IVIG. However, the only problem with this one was that the statistical significance was only seen in one study. And then like most patients, responded well to TPE, and patients that were in acute crisis when they were treated with TPE had shorter ventilation times in comparison to IVIG. Now, where we didn't see the difference was really, and where IVIG was, seemed to have more positive benefit, was in the shorter overall hospitalization time. And again, I will postulate that the reason why IVIG was correlated to have shorter overall hospitalization times is because it's more readily accessible. And oftentimes, patients do come into the hospital when therapeutic apheresis is not present, or, there is a delay in the transfer of the patient to a hospital that has TPE. So they receive IVIG before TPE, and that, muddies the water a little bit. So a lot of it is really the fact that, sometimes IVIG is given prior to TPE, and it's hard to, it's hard to tease out which one had the true clinical benefit. But, a lot of you might ask me, so is it, I've heard that IVIG is actually cheaper than therapeutic plasma exchange. And there was actually a study that was done by Jeff Winters, which actually shows that IVIG is not less expensive than therapeutic plasma exchange. And so, that itself is, really, if there is a hospital that has therapeutic plasma exchange and it's readily available to a patient in crisis, I would venture to say that I would want to do therapeutic plasma exchange more than IVIG. And let me tell you the other reason why I like TPE more than IVIG. IVIG, as you know, is does put patient at thromboembolic risk. And I have had a few patients that have suffered strokes when receiving IVIG. So I tend to be very averse to patients having poor outcomes. And so, I would prefer to use TPE than IVIG. I would also, when taking a look at the overall risk of medications to TPE, many of you know that, most treatments are either metabolized by the liver or the kidney. And over time, as the medications have to be metabolized in these two areas or secreted through the kidney, what happens is that there is organ damage that is done to these organs versus TPE. There is really, been used long term. There's really no, there's been no long term issues with it. Okay, so why am I promoting for the long term treatment of neurological disorders with TPE? It's only because there are lots of studies that are being done, which shows that therapeutic apheresis, when performed by individuals that are technically skilled and trained and know exactly what they're doing, it is a safe and effective long-term treatment with very mild adverse events in comparison to everything else. And, there, as I showed you with myasthenia gravis, most patients actually had very good positive outcomes, using therapeutic apheresis modalities. Okay, wow. I am really filling up the hour. Okay. So what are the current challenges? So, the current challenges right now, as I've been alluding to a few times over and over again, is that because therapeutic plasma exchange has not been promoted as a treatment of choice for individuals that are outside the hospital, we don't have a lot of long-term apheresis treatment plans, like, what really works and what doesn't. And we also, we have seen, like, when patients are acutely receiving TPE, in the hospital, there are no long-term side effects, but we don't know that when they're truly moved into an outpatient facility. Although data from European and Canadian institutions that tend to do it more on the chronic side have shown no has shown this very mild adverse event as it relates to the patient receiving the TPE, or like when they're receiving the TPE and not really after they receive the TPE. And we're continuously trying to elucidate, how to assess objectively how the patient does with therapeutic plasma exchange. And again, you can see that, I participated in a study that, we are using various outcome measures to better understand how to treat patients in chronic situations that are stable, but, prevent them from entering the hospital with plasma exchange that is done in a setting outside the hospital. Okay. So what have we covered so far? So I hope I have impressed upon you that therapeutic apheresis is an efficacious treatment, both in the short term as well as long-term management of patients that have myasthenia gravis. While there are many postulated mechanisms, we certainly know that the removal of antibodies creates this immune system alteration, which ultimately is of benefit to the patient. When TPE is performed in an outpatient setting by technically trained staff using peripheral venous access, it is safe for the patient, and it typically lasts less than 3 hours, depending on, the height and weight of the patient. So all of that, all of that is important. But, for the most part, I'm a really strong advocate for the use of therapeutic plasma exchange. And as you can see, as I go to CMS, talking about increasing access to patients, that are not in crisis to actually receive care in an outpatient facility, I think it's really going to transform, the care that is received by patients with myasthenia gravis. Thank you.
Dr. Ike, that was amazing. As somebody that received plasmapheresis for so many years, I feel like I learned so much from your presentation. So
Oh, thank you.
fantastic. Do we have any questions? Any additional? That was a lot of information that Dr. Ike went through. So questions?
Yeah, and I hope I didn't use a lot of like medical jargon. I hope I distilled it in a manner that was understandable. Although I have to say, I threw myself on one slide. If a few of you are lost, I'm sorry.
It looks like we have one piece in the chat. It says, I was confused by the TPE for ocular MG. You said it works more slowly.
That is correct. It takes a little bit longer time for TPE to be of benefit to ocular myasthenia gravis patients. So in most patients that have ocular myasthenia gravis, the time, so let me just clarify one thing, right? So if patients that are newly diagnosed with myasthenia gravis, meaning that, like we have individuals, that are diagnosed with myasthenia gravis who have lived with the disease for a really, really long time, right? So when I mean like any treatment is going to be more efficacious when your time to diagnosis is actually when your symptoms begin, right? So like if you're diagnosed when your symptoms begin, right, you're not going to have that autoantibody burden than someone who, had like, let's just say, they live in a rural community or in a community that don't have a lot of specialists, right? They've just, they're like, oh, well, my eye looks a little like maybe I'm seeing double vision, but maybe not, and they just live with it for a while and it takes them a long time to actually get diagnosed. You can imagine that the disease burden is a little bit higher. So for that patient versus a patient who, their time to diagnosis was short, that person is going to have a faster response than a person who has been living with the disease for longer. But when you actually compare a patient that has ocular myasthenia gravis to other types of myasthenia gravis, they actually do take a little bit longer, regardless of the treatment, to actually see improvement with the treatment.
Thank you. It looks like we have another question. How often do you need TPE?
So again, this one thing I love about therapeutic plasma exchange is that it really depends on the patient. So certain patients one, if you are a patient that is in acute crisis, we traditionally do therapeutic plasma exchange at least 5 to 7 times alternate, with 1 day space. And the reason for that 1 day space is because we want to suck out the autoantibodies, like I mentioned, from the bloodstream, create that concentration gradient so that immunoglobulins, especially IgG, will diffuse down, right? We also know that there are different subclasses of immunoglobulins within IgG, right? IgG3 tends to be more, like mediate more disease than not. So, all of that actually plays into effect. But for the most part, a patient in acute crisis will receive 5 to 7 treatments, right off the bat. And then depending on where the patient's symptom is, they will go through a personalized routine of when you should get TPE. Now, if you are a patient that has been living with myasthenia gravis, for a really long time. Allison, you probably can attest to this, right? You know exactly when you need it. And so you're like, okay, so I can last maybe, 2.5 weeks, without a treatment, and then you will come in for that treatment, and then you will, get another treatment either the next, like not, I prefer to always give a gap between the treatments, right? So that again, the immunoglobulins can be, have that concentration gradient. But again, it all really depends on the patient, and the symptomologies that they present with and how responsive they are to the treatment.
Sure, thank you. One more comment. I always hear it's too hard to do because you need a port and too difficult to get as an outpatient.
Yeah, thank you for that. So here's the thing. So you can actually receive therapeutic plasma exchange through peripheral access. So what do I mean by peripheral access? So all you need to do is have a really good antecubital vein, right? Or a larger blood vessel in your arm which can handle a 17 or 18 gauge needle that is going into your arm. If you have good venous access, guess what? You can actually receive TPE peripherally. You don't need a port. You don't need a central line. You don't need any of that. I know that is contra to what everyone else says, but it is really, we're hoping to make it more patient accessible by saying that, hey, if you want to receive TPE in an outpatient setting, right, we will do a venous assessment on you. And if you have good veins, guess what? We will do the treatment peripherally for you. But in addition to the port, like let's talk about port for a second. The ports vary, right? So you can have ports, you can have fistulas, you can have grafts. All of those things can actually change how you receive the apheresis procedure. If we talk specifically about port, there are the ports that it's like a circular dome, otherwise known as vortex and other names, which has like sort of like a plastic or um, center. Those, tend to have a lot of issues because of the sludging and, like even if we put heparin, post procedure, it still, can kind of clog up. So I agree with you that ports are really difficult. However, there is a port that was created specifically and is FDA approved for apheresis called the BARD Power Flow. Again, I'm not being paid by any of these companies, I'm just letting you know these things. The only company that, I am a consultant for is Terumo, which is the device manufacturer for the apheresis machine. So I am a consultant for them, but in the US, there isn't a lot of choice as to which device can be used. It's either Fresenius or Terumo, and Terumo does have a larger market share and is more accessible to most of us. And because I do have a deep passion in apheresis, I do work with them to increase patient access to therapeutic apheresis. So that's the only company, that I have a consulting agreement for. But having said that, the BARD Power Flow is a apheresis FDA approved port that is placed by interventional radiology, which, doesn't have the usual sludging issues that the vortex port does.
Thank you. Any other questions? And we'll get this wrapped up. Doctor, I thank you so much for taking time out of
You're
your
so welcome.
to educate us. This was fantastic.
Absolutely. I appreciate everyone's attention and really appreciate the time that you've given me.
Wonderful. Well, I think that's it, guys. Thank you for joining us, and we'll see you again next time. All right. Bye-bye.